The histopathological assessment of this cervical transformation zone specimen demonstrates a classic high-grade squamous intraepithelial lesion, specifically staged as cervical intraepithelial neoplasia grade 3, which is defined by the expansion of immature dysplastic cells across the entire thickness of the epithelium. The normal orderly maturation sequence from the cuboidal basal layer to the flattened glycogenated superficial squames is completely obliterated and replaced by a monotonous population of basaloid cells with scant cytoplasm and indistinct borders. High-yield cytological features include significant nuclear pleomorphism with hyperchromasia and a markedly increased nuclear-to-cytoplasmic ratio, while the chromatin appears coarse and clumped with occasional prominent nucleoli reflecting active transcription of viral oncoproteins. Frequent mitotic figures are visible throughout all levels of the mucosal thickness, including the uppermost layers where mitoses are never found in physiological states. These neoplastic cells are driven by the integration of high-risk human papillomavirus DNA into the host genome, leading to the overexpression of E6, which mediates the ubiquitination and degradation of the p53 tumor suppressor protein, and E7, which binds and inactivates the retinoblastoma protein. The inactivation of the retinoblastoma protein releases the transcription factor E2F, promoting unregulated entry into the S phase of the cell cycle, and a characteristic compensatory upregulation of P16, which can be confirmed by diffuse block-positive immunohistochemical staining. A prominent finding in this section is endocervical gland involvement, where the dysplastic squamous epithelium has tracked down into the underlying endocervical crypts and replaced the simple columnar epithelium. It is essential to differentiate this from true invasive squamous cell carcinoma by observing that the nests of cells retain smooth, rounded borders and are still confined by a basement membrane, without a surrounding desmoplastic stromal reaction or the presence of angiolymphatic invasion. In many cases, the transition between the dysplastic squamous cells and the remaining mucin-producing columnar cells of the gland is abrupt. This specific finding of gland involvement increases the surface area of the lesion and is a known risk factor for recurrence after local excision procedures like the loop electrosurgical excision procedure or cold knife conization. Clinical correlation involves recognizing that while the squamocolumnar junction is the most common site of origin, the lesion can extend deep into the cervical canal, making it less accessible to standard colposcopic visualization. The absence of coilocytes, which are more typical of low-grade lesions, reflects the highly undifferentiated state of the cells as they prioritize rapid proliferation over viral assembly. This total thickness dysplasia represents the final pre-invasive stage before the basement membrane is breached to become a microinvasive carcinoma.